I welcome you all for this day 9 session of this Pediatric Acute Care Training Lecture Series 2. It's part of the COVID Pulse initiative of the CMC Vellore. And today is the day 9 session. And we are having the monitoring in ICU and ABG by Dr. Siva, Moderators Muniya and Abhishek. And today's moderators, Dr. Muniya and Dr. Abhishek. Dr. Muniya Thokchom is the Pediatric Intensivist at Mother's Care Children's Hospital and Research Center, Imphal, Manipur. After her DCH and MD PEDS from CMC Vellore, she did the IDPCCM, the fellowship of the KAP College of Pediatric Critical Care, and she did the fellowship in Pediatric Intensive Care at Sick Kids, Toronto, in Canada. And she is working as a pediatric intensivist at the moment, and she's past faculty in our ICU for a long time, as well as is a quite active member of our team, and she was there and along with Pragadish in the Pediatric Acute Care Training in Gorakhpur Division. She used to take part. Welcome you, Muniya, and thank you for joining today. And
thank you so much, sir.
Thank you. And we do have Abhishek Chakraborty, is a consultant pediatrician having his own clinic in Silchar and Assam. And he's one of the part of our excellent past fellow group. And he did his MD PEDS from Guwahati Medical College and IDPCCM of the IAP College of Pediatric Critical Care and the postdoctoral fellowship in Pediatric Intensive Care at CMC Vellore. And both of them, Muniya and Abhishek, are going to moderate. Over to you guys to introduce the topic and the speaker.
Dr. Siva Vyasam, currently working in Pediatric ICU, CMC Vellore as an assistant professor. He did his DCH and MD from CMC Vellore, and he is at present working as a faculty, and he is IP AHA Pulse instructor also. Welcome, Siva.
Thank you, Abhishek. Thank you, Muniya.
Good afternoon, everyone. Today is one of our topics on this ongoing series of pediatric acute care training in regards to the ongoing pandemic of COVID. So Siva is like Abhishek has said, Siva is an assistant professor in our PACU CMC Vellore, and he's going to talk to us regarding two very important topics about monitoring a sick child as well as how to interpret an arterial blood gas, which are an integral part for managing any sick child. So I hand over to Siva, and let's all concentrate. If anybody has any questions, they can either put in the chat box or at the end of the presentation, we can have a discussion on that. Siva has got quite an extensive topic. So Siva, over to you.
Thank you, Muniya. Thank you, Abhishek. Thank you, sir. So I will start sharing my... So, sir, can you hear me and can see the slides?
Yes, yes, we can hear you well and see the slides. Yes.
Thank you, everyone, for giving me this opportunity. So today my topic is on monitoring and ABG interpretation, mainly case-based studies. So what I am going to deal in the next 1 hour is, I'll just with a brief introduction, I will just talk about one PUSE concept and hemodynamic monitoring and respiratory monitoring, especially for the sick children, and ABG stepwise approach and case-based discussion we will have. So as this is dealing with monitoring, so why do anyone needs to be monitored? So the objectives of monitoring, it can be like a diagnostic, mainly to assess how severe is the child, or a therapeutic, so to indicate the need and timing when you need intervention, or surveillance, once you give fluid response, how is the response to that? So to assess the response and to prognosticate the trends during the monitoring, sometimes it may predict the outcome, how sick is the child going to be, and warning, like audio visual alarms in various monitors, which will alert the clinician to untoward events. So monitoring is part and parcel of any intensive care unit. So I will just start with a case scenario. So this is a Master C, 10-year-old child weighing 30 kilos. He presented to emergency with MISI with RT-PCR positive. His consciousness is irritable. His breathing is normal. His color is pale. Okay. And airway is maintainable. Breathing is normal, no distress. Circulation, his heart rate is 160 per minute with CRT prolonged. Peripheral pulse feeble, and blood pressure is 80/60. He's a 10-year-old child, and temperature is 102.4. and disability is irritable, and exposure you have noticed blanching rash is there. So this is the child. So anyone want to comment on the physiological status here in the chat box? Anyone? So for the sake of time, I will just go on. So this child is like a whatever we can see is a missy child. He is having temperature, high grade fever with poor perfusion. So physiological status, he is in hypotensive shock, probable septic shock. So we have received in a call after giving the fluid bolus, they noticed in the casualty the child also has gallop. So they thought it's like cardiogenic shock and started on adrenaline. They want to shift the child to HDU for management. So what all do you monitor in this child? And what's the PACT score for this child? So that's what I'm going to deal here. What all we will monitor, like this type of child, if it comes to your unit, what you are supposed to monitor, and what is PACT score. So to introduce the PACT score, the first concept is this pediatric early warning score. You can see here A, B, C. So A is like a routine kid, any kid like a normal kid admitted with some problem in the ward, with routine care needs, child become better and discharged. The other type of the children who may need increasing care needs. So at that time you have to identify them and we have to appropriately intervene so that we can bring them down. If we don't intervene here and identify and intervene, they may go and worsen to cardiopulmonary arrest. So how can we identify this? So that is what this pediatric acute care score. So what are the parameters in this? Respiratory component, cardiovascular and behavior, and the comorbid factors like in oncology, immunodeficiency, cardiac disease, chronic lung disease, or chronic renal disease, or malnutrition. So the scoring is there here. This was discussed detail in the previous lecture. So I will just quickly run through it. So behavior, mainly you have to see how is the child irritable or lethargic. Cardiovascular, how is the perfusion of the child, how is tachycardia, CRT, and respiratory, how is the child's tachypnea or work of breathing. So depending on that, you will get a score, and how you will interpret the score. So CMC PACS assess admission on ward. If PACS score is less than 4, you have to do Q4 early monitoring. If it's 4 to 6, you have to monitor little frequently, like Q2 early monitoring, and follow the standing orders and inform the doctors. And PACS more than 6, it's like a sick child who needs HDU or ICU. Okay, so what will be the score for this child here? In our case, the child is irritable and also CRT is prolonged, but there are no comorbid factors. So his PACT score is 4. So he needs close monitoring. So what are the different ways of hemodynamic monitoring? So always the clinical assessment will precede everything. Okay, so clinical assessment, heart rate, CRT, urine output, sensorium, mottling score, and basic monitoring and assessment of global perfusion, some preload monitoring parameters, and some advanced monitoring like cardiac output monitoring, and by assessing now is the heart contractility and tissue perfusion. So we will discuss in details. So these are some of the common monitors in our ICU, mainly Philips MX450 and Nihon Kodan monitors. It's like a multi-channel monitors where we can see heart rate, saturation, blood pressure, respiratory rate, ETCO2 also can be connected. So coming to the basic physiology. So delivery of the oxygen in any shock, what is the problem? The delivery of the oxygen is decreased. So the delivery of oxygen depends on your cardiac output and your content of oxygen. And indirectly, the cardiac output depends on your heart rate and stroke volume. And stroke volume depends on your how much blood is coming to the heart and how good his heart is functioning, and against how much resistant heart is pumping. So that is your preload, contractility, and afterload. And your content of oxygen is carried by the hemoglobin molecule. So hemoglobin and the saturation of the oxygen is the main determinants for this content of oxygen. So the clinical assessment, as I said, these are the normal heart rates according to the AHA. You can see the heart rate is very, very important sign, especially in pediatrics. They can have tachycardia. So you can see here, this is one of the post-op TOF child repair. You can see this blue one is your temperature monitoring, and the red one is your, blue one is your temperature, and red one is your heart rate. So you can see over the time, the tachycardia is worsening. Okay, so that will give us a clue. So we have to be very red alert at this point of time. So what might be the causes for abnormal heart rate? So tachycardia can be due to respiratory distress, child might be in the shock, or child might be fever, pain, dehydration, hemorrhage, myocarditis, or bradycardia. Most common cause of bradycardia in children is secondary bradycardia and secondary due to hypoxia. So that is one of the things. That's why in any child with bradycardia, first with adequate oxygenation and perfusion, we will say. The next comes always heart rate and rhythm goes together. So always look into the monitor for the rhythm. See, suppose in this child, you have seen the rhythm like this. See, in between the normal sinus rhythm, you can see some wide ectopic type of rhythm. So these are known as ventricular premature contraction. So especially in a septic shock children with sepsis-induced myocardial dysfunction, you will see this. You have to check the magnesium level and it has to be corrected. Okay, it indicates the heart is weak, contractility is poor, this ventricular premature contractions. So we finished heart rate and rhythm. Next clinical thing is, how is the pulse? You can see for the central pulse in various places and peripheral pulse. If in the infant, always look for the brachial pulse. In the children, carotid or femoral pulse. And how is the volume? Pulse volume is also important, especially in the shock. Okay. Next is your CRT. So how you will check the CRT? So always to evaluate the CRT, lift the extremity slightly above the level of the heart and press on the skin and rapidly release. Okay. A CRT of less than 2 is normal. There are some studies which have done. They have told that CRT of less than 2, it provides excellent negative predictive value for a cardiac index of less than 3 and SVC oxygenation saturation of more than 70%. So there is one recent study published in the adult group, RCT, for the septic shock patients. One group into peripheral perfusion group where CRT, till the normalized CRT, they have continued the resuscitation. The other group till normalization of lactate. The primary outcome is all-cause mortality at 28 days, but there is no significant risk difference between these two groups. So this was one of the recent RCT done, but mainly in the adult population. And the other important thing is, how is the color of the skin is also very important. Okay, suppose child color is pale, what does it indicate? Especially in the ICU setup and the emergency setup, child might be having poor perfusion. And mottling also is very important because child, because of hypoxia, hypovolemia and the shock. Peripheral cyanosis or acrocyanosis in newborn, it might be normal, but in the sick child, it might be due to your shock. And central cyanosis in terminal stages of respiratory failure, you can have, or cyanotic congenital heart disease. So skin color gives us a very important clue for help in the diagnosis and the management. So what is this one? You can see here, this is the infant. So lacy reticular pattern. So this is called as mottling. It's also termed as dyschromia or livido reticularis. So it's like a patchy skin discoloration. So this is mainly due to the blood vessel changes due to hypoxia or hypovolemia. So usually mottling will begins at the knee and it can be quantified using a mottling score. Okay, so it's like a score 1, it's like a small area of mottling localized to the knee, and score 2 that extend beyond the superior border of kneecap, score 3 it does not extend beyond the mid thigh, and score 4 it not going beyond the groin fold, score 5 it's beyond. So the mottling score, you can see how is at the time of admission, how is after you started your resuscitation and treatment. That is also very, very important. The very, very important thing is urine output. Okay, any shock child, you have to catheterize the child, you have to monitor the urine output because it's the more sensitive to changes in the renal hemodynamics than your biochemical markers. You can pick up the acute kidney injury. You can see the criteria, various criteria were given. In that, one of the important criteria is your urine output criteria. Sometimes it might be less specific. The severe ARF can exist despite normal urine output in sometimes, but changes in the urine output, always remember it occurs far before your biochemical changes, before your creatinine goes up and all, your urine output is the first. I will just show you some of our monitoring sheets. This is how the urine, suppose is a 20 kilo child. You can see urine output every hour, 20, 30, 25, 40. So you're happy with that. Okay, so this is the thing. And at the same time, you can see here, this is the same child, 20 kilos child. Slowly till here it was okay. After that, you can see here 30, 25, 15, 5, 5, 5, and it's nil. Okay, so at that time, you have to be alerted. Okay, so the child is going into acute renal failure, acute kidney injury. And the other thing in the ICU setups, especially, you might be seeing this total intake, output, and net balance and cumulative balance is very, very important, because there are a lot of studies nowadays like fluid overload. What is fluid overload? Total how much intake minus total output divided by pre-admission weight into 100. So they have suggested that if fluid overload of any child more than 10% to 20%, the mortality increases from 40 to 60%. And what is the normal urine output in infants and young child? It's 1.5 to 2 ml per kg per hour. In older children and adolescents, it's 1 ml per kg per hour. And the sensorium, it's very important. Most of you know this pediatric Glasgow Coma scale, eye opening and motor is same. And the verbal is a little bit different depending on the age group. So score 15 is normal. Just remember, an awake and adequately talking child is the best indicator of adequate cerebral perfusion. Okay, so especially in the shock child, because of the hypoxia, they may have decreased cerebral perfusion and the sensorium might be low initially. But once you give the fluid bolus, once you restore the circulation, the sensorium may improve. So the monitoring the GCS is also very, very important in the ICU setup. This is one of the monitoring of an intubated child. That's why verbal is T, 2T by 15, it is documented. So we have talked about the basic things. Next important parameter is the blood pressure. So what is NIBP? It's a non-invasive blood pressure, which is based on your oscillometric method. Okay, as blood flows through your arteries, the pressure in the cuff will oscillate. So the onset of the measurable oscillations is your systolic pressure. The maximum level is your MAP, mean arterial pressure. Point where the oscillation stabilize is your diastolic blood pressure. So the MAP is the reliable one. The other two, systolic and diastolic, are derived. But what is the major limitation by having non-invasive blood pressure, especially in the children with shock and all? Because of hypoperfusion and peripheral vasoconstriction, the readings might be false. Okay, it's not a continuous monitoring. It's like a intermittent blood pressure monitoring only. And it also depends on choosing appropriate cuff size and placement. You can see here 99 by 70 with MAP is given in between 77. And these are the various cuffs available: infant, pediatric, small adult and adult. And the width of the bladder should be covered 2/3 of the upper arm, and the length of the bladder should encircle 80% of the arm. And the lower edge of the cuff should approximately 2.5 centimeter above the antecubital space should be there. And this is the neonatal BP cuff which we use. And how much is the cutoff? So usually this is the systolic blood pressure, less 5th centile. So for the neonates, if it's less than 60, it is called hypotension. For the infants, less than 70. For the children, it's less than 70 plus age into 2. And more than 10 years of age, it is less than 90. So we already discussed about the caveats of this non-invasive blood pressure. That is the this one. So we need to have some blood pressure monitoring which is continuously monitoring. So what is that? That is your invasive arterial pressure monitoring, which is a gold standard for pressure monitoring in our ICU. So it is affected by the vascular tone, which in turn depends on the volume status and sympathetic tone and use of whatever the medications they use. And it has a transducer which converts all the pressure waves into electrical signals. And you can see somewhat like this arterial waveform. Okay, in which all children you will put? All the sick children, critically ill children with hemodynamical instability or severe respiratory distress, or the children who's on anti-hypertensive medication titration, and post-op children, especially post-cardiac surgery children, or frequent blood sampling children, you will put an intra-arterial line. What are the contraindications? Like negative Allen's test, or infection of the local site, or if they're having any peripheral vasculitis, like Raynaud's phenomena or thromboangiitis. These are some of the contraindications. And you can see that this is something known as distal pulse amplification. These are the different arterial waveforms from the different sites. You can see the morphology of the signal changes depending upon the changing characteristic of the vascular tree. So as the waveform is measured from the aorta to the radial artery, you can see the systolic upstroke gets steeper, diastolic upstroke gets narrower. But the mean arterial pressure, however, remains same. So that is the main thing here. The area under the curve remains same, even though the systolic peak changes. This is something known as distal pulse amplification, depending on which site we are putting the arterial line. And the one thing always remember, and I want to re-emphasize again and again, this pressure is never equal to flow. Okay, it's not always equal to flow. So by increasing your blood pressure, don't think your flow to the organs also improved. Suppose the numbers might be good, but it may not translate to your organ perfusion. Suppose your blood pressure on inotropes, it may come up to 120/80. You might be seeing the monitor and saying, oh, blood pressure is normal, but it is on the extent of your SVR, that is systemic vascular resistance. Because your SVR is increasing, your flow to the other organs will decrease. So pressure is not always translates to the flow to the organs. So that is the one of the important thing we have to remember. And there is something in the arterial line that is known as dampening, depending on the circuit. Suppose if this over compliant tubing, or if there is any air bubbles, clot, stopcocks, you will something see like this. This is the over dampening of the arterial line, arterial waveform. Sometimes you will be having under dampening, where you will have sharp and tall spikes, which is mainly by the excessive tubing length. Okay, in whatever is the dampening, the map will never change. Okay, mean arterial pressure will never change. So how you will check that? By something known as square wave test. Okay, so you can see here she is flushing at the same time. So what happened here? You can see here. So usually there will be some amount like 1 to 3 ml per hour in that catheter tubing will be there. By increasing it, you are increasing the flush flow rate to 30 ml per hour. Okay, for few seconds. You can see. Sorry. You can see here it is flushing. So once that flush test is done, you can see there is some oscillations, and then it will take to the normal waveform. So depending on how much oscillations, you can find out whether it is over dampening or under dampening. Usually if it's a normal waveform, 1 to 2 oscillations will be there before return to traceling. If it's under dampening, it will be more than 2 oscillations. If it's a over dampening, it's less than 2 oscillations. Okay, just remember this. This is one of the tests which can be done at the bedside. So what happened to our child? His airway is maintainable, breathing mild distress, and circulation, heart rate is 150. You have started on adrenaline infusion. Intra-arterial blood pressure is 90/50. You have started on high flow nasal cannula connected to the monitor, started arterial line CVC, urinary catheter, his urine output is 0.5 ml per kg per hour, and this is the blood gas. So you can see here, the heart rate is definitely decreased, CRT is better, pulses is still feeble, but your blood pressure is more or less, it is much better. Temperature is still there. So even though the grossly your numbers looks okay, you can see here the metabolic thing, your lactate is very high. So the numbers are good, but your microcirculation is not showing like that. So there is some dysynchrony between your macro circulation and your microcirculation. So that is where your always circulatory shock, we will try to target this macro circulation, that is your heart rate, BP, and urine output, all the other things. What about the microcirculatory changes? That is very, very important. So microcirculatory changes mainly depends on your lactate, SCVO2. So we will discuss in detail what are those things. So lactate is one of the byproduct of the tissue metabolism. Any anaerobic things, the glucose pathway will move into the pyruvate and it will change it to lactate and it will be increased. Normally it is clearly quick by the liver by conversion into pyruvate, and lactate value less than 2 is the normal acceptable value. And if lactate clearance within the first 6 hours, if it's not happening, then it might be, we have to think the child's outcome, it might be bad. Okay, there are some studies which showed if the lactate clearance is good within the first 6 hours, they may have a good outcome. And what are the causes of high lactate? This is Cohen-Wood classification. The most common is type A, hypoxia. Why it will cause, I will discuss in the next slide. Mainly is the shock. And the type B, B1, B2, B3 it is divided. B1 is mainly due to systemic things like hepatic or renal failure. B2 is toxin and drugs. B3 is some metabolic syndromes. So you can see here the delivery of oxygen and consumption of oxygen. Okay, so this you just remember like your bank balance. Okay, so due to COVID times and all, you're not getting any salary, you have to depend only on your bank balance. But how much bank balance you have? You may have only till some extent. Okay, so like the tissues also, they have something known as reserves. It can extract the oxygen, even though the delivery of oxygen is decreasing, your consumption of oxygen, it will try to maintain by using those reserves. But after certain point of time, it will be fully dependent on your delivery of oxygen. Okay, so if your delivery of oxygen decreases, your consumption of oxygen also will decrease. So at that point only, your lactate also will go up. So that is the point of critical point of dysoxia. So this is in the normal state. In the sick children with shock, this curve moves toward the right and up. You can see here, this point moves towards the up, and this point achieved very early. Okay, so this is very, very important. That's why the lactate clearance is also very important. And this delivery of oxygen, I have already discussed, depends on your cardiac output, and content of oxygen mainly depends on your hemoglobin and your oxygen saturation. And the other important thing is your tissue extraction. You can see here the arterial oxygen, and this is the venous side oxygen. Here tissues extracted some oxygen. So what you are measuring by SCVO2 is measuring the venous oxygen by putting a catheter in the SVC. You are taking a gas from there and you're checking the saturation there, oxygen saturation. So this tissue extraction depends not only on the supply and demand, but also on the ability of how the tissues are extracting. So I will give you 3 scenarios. So you can see here, this is the arterial side, this is the venous side, this is how the oxygen is extracted. So which one do you think is the good, better, bad, like that? So you see the arterial oxygen is 97, the venous side is 70, tissues extracted is 27. So it's more or less, it's okay. So I'm happy with this scenario. Whereas the other one, arterial is 97, venous side is 60. Okay, the tissues are extracting more, means tissues are extracting, are hungry. So here your SCVO2 is low. What is the reason for your SCVO2 low? Either your delivery of oxygen is low or your consumption of oxygen is high. The consumption of oxygen is high due to increase your metabolic demand, like in shock, fever, seizure, or pain, agitation. Delivery of oxygen is low. The carrying molecules for oxygen might be low. That is anemia, or heart is contracting very poorly. So you may have to start some inotrope, or child might be having hypovolemia. So you have to address their issues. Okay, so I am little sad with this. What about the next scenario? The venous side oxygen is high, it's 85, but the child is in shock. Oxygen extraction ratio is only 12%. Here I am very depressed because your tissues went into a state of histotoxic hypoxia. Okay, your SCVO2 is high, especially in a shock child. That might be because of your tissue histotoxic hypoxia. So that's how the importance of your SCVO2 monitoring, especially in a sick child in ICU. If you have a central line like IJV, take a gas from there and look into the SCVO2, and depending on that, you will know in which way we are going. So the same child is heart rate is 150, pulse is feeble, blood pressure 90/50, his temperature 100.4. So he's on adrenaline infusion, high flow. Your SCO2 measured was 60. Your measured hemoglobin was 12. You'd want to give 5 ml per kg fluid bolus slowly. So how you will know this child is fluid responsive or not? So that depends on what you will see. If you give fluid bolus, you can see for positive effects and negative effects, like decrease in the heart rate, improvement in the sensorium, improvement in the perfusion and all. And in the negative effects, the worsening of the respiratory distress, worsening of the shock, increasing in the liver size, and presence of the gallop. So everyone, I think note this Frank Starling curve. This is the steep portion where if you give the fluid volume, the response is good and there is increase in the stroke volume is high. Whereas in this flat portion, if you give the fluid, the stroke volume increase is very less. Okay, so you have to find out the steep portion. This is the same thing here. If at point A, if I give fluid bolus, you can see how much the stroke volume increased compared to point B where you give. At the same time, the extravascular lung water increased is very less if you give fluid at point A. Whereas here in point B, if you give the fluid bolus, what happened? The stroke volume increase is less, but your extravascular lung water increased. So it's very important to identify this flat portion. So there are so many indices are there, static parameters, dynamic parameters. So I'm not going in detail. What are commonly used, I'm just going to tell, just looking at the monitor. So this pulse pressure variation is one of the things which you can look into the monitor if you have an arterial line. See, you can see the BP tracings here. So what is the basic physiology behind it? During inspiration, just remember the LV stroke volume increases. Okay, and the RV stroke volume decreases. Especially these changes are exaggerated in the settings of your hypovolemia. Okay, so that's why you can see here inspiration, the fluid is more. Here the wave is going up, and the expiration it is coming down. So there is a formula for that. If pulse pressure variation, if more than 13%, it indicator of fluid responsiveness. There is some other variations which we can do, like systolic pressure variations or stroke volume variations, which I'm not going in detail here. And what else we can see? Apart from pulse pressure variation, if you have an ultrasound, try to look always into the IVC. Okay, you can see here, the IVC is collapsed. And again, IVC depends on whether child is intubated or not. If it's a spontaneously breathing child, you will look into the collapsibility of the IVC. And if it's a mechanically ventilated child, you will look into the distensibility. So if the IVC is variable between your inspiration and expiration, if it's more than 12%, that indicates child needs in the steep portion where he needs fluid bolus. Some other tests like passive leg raise test also can be done from a 45-degree semi-recumbent head position to 45-degree head leg up position. So what it is doing, it is shifting the blood volume from the legs everywhere to the heart. So it will increase the preload. So it should show the transient increase in your blood pressure and the stroke volume. So this one it can be done especially in the spontaneously breathing children and in the patients who are not in sinus rhythm also, whereas the other two which may not be done. There are some contraindications, like if you are having intra-abdominal hypertension or child is having raised ICP features, you may not do this. So there are some recent gadgets which came for monitoring of cardiac output, like some non-invasive cardiac output like ultrasonic cardiac output monitors or icon monitors, or something known as the pulse-induced counter cardiac output monitoring using pico catheters. These are the latest things. And the NIRS can be used based on this modified Beer-Lambert law. It mainly helps in knowing the regional saturation of the oxygen. Okay, so the values might be between 55 to 75. It mainly helps in the renal circulation, in the cerebral, and in the post-op cardiac bypass children. So if anything less than 40 to 50% or change in the baseline greater than 20%, you have to think of there is a regional hypoxemia. So that is one of the newer thing. And this one I'm not going in detail. Mainly these are the newer gadgets, mainly to see how is the microcirculation by using video microscopy. There are some techniques like orthogonal polarization spectral imaging, side stream dark field and incident dark field, which I'm not going in detail here. So at the end of the hemodynamic monitor, these things are very, very important. What is our first therapeutic endpoint goals in the septic shock? Your CRT should be less than or equal to 2 seconds. Your threshold heart rate should come down at least by 20%. There should be normal pulse with no differentiation between the quality of the peripheral and central pulse, warm extremities. Urine output should be greater than 1 ml per kg per hour. Normal mentation, normal blood pressure, normal glucose. And beyond first hour, along with above 8 points, as we mentioned, the SCVO2, the venous side oxygenation should be more than or equal to 70%, normal perfusion pressure, and we have to optimize the preload and normal anion gap and lactate. So what happened to our child? So he's on adrenaline infusion. You can see after giving the fluid bolus, child tachypnea worsened, respiratory rate of 60 per minute with subcostal, intercostal crepitations are there. He's on HFNC, he's not maintaining saturation, 88% only. His circulation is more or less okay on adrenaline 0.3 mics. So you started on non-invasive ventilation 12/8 PEEP with FiO2 of 100%. So what do you monitor? So respiratory monitoring in PICU is an essence of the critical care, be it clinical or invasive or non-invasive. It remains crucial in overall assessment of the sick child with cardiopulmonary problems. So physical examination, what all respiratory rate, how is the effort of the breathing. Non-invasive, mainly saturation, your pulse oximetry, your ETCO2, and ventilator PAV loop and X-rays, and ultrasound if you have. And invasive monitoring is your arterial blood gas, which we discuss in detail. So these are the normal respiratory rate. This is measuring the respiratory rate is easy and has a good accuracy in prediction of LRI and presence of increased work of breathing, like flaring of Allen-Azay, suprasternal retractions. How is the work of breathing? That is also very, very important. And this was already discussed in the previous lecture, the difference between respiratory distress and failure. I just want to reiterate the respiratory failure, the saturation less than 90%, even on high flow oxygen, you will say it's like a respiratory failure, and the sensorium is low, then you will say it's a respiratory failure. These two things are very, very important. The next thing is your pulse oximetry. Pulse oximetry, it's also called as fifth vital sign. It's based on your Beer-Lambert law. This is common one which is used everywhere. It's a simple, non-invasive, and it's continuous method of monitoring the oxygen saturation of arterial blood. Okay, it's based on Beer-Lambert law, I already told. So it gives fairly good idea of not only saturation but also oxygen content. See, again and again I'm saying the content of the oxygen is mainly depend on your hemoglobin and your saturation of oxygen. Okay, provided your other parameters like carboxyhemoglobin and methemoglobin are normal range. Okay, so the normal SpO2 for adolescents and adults is greater than 95%, and for children a level greater than 90 to 92% is normal. Okay, so always the interpretation of the SpO2 should be done in context of this. What is this curve? Oxygen dissociation curve. Because there are some conditions which cause left shift. They can have normal saturation, but patient may be hypoxic. And similarly, there are some conditions which causes right shift, like increase in temperature, increasing 2,3 BPH, acidosis. They may have low SaO2, but the patient may not be hypoxic. So we have to always interpret the SaO2 depending on whether is there any conditions causing left shift or right shift. And what are the limitations? The shape, as I already mentioned, if there are any carboxyhemoglobinemia, methemoglobinemia, it may show low value. And the dyes, if you are using any dyes or nail polish and skin pigmentation, and especially in the sick child, the poor perfusion. Okay, if the low perfusion states, then also it may not be useful. So you can see here the pulse oximeter, the waveform. You can see the waveform, that is very important. And some monitors nowadays, they are coming with the perfusion index also, PI, with Massimo technology, they're coming. So what happened to our child is on NIV on 12/8/80 with 100% FaO2. You can see his sensorium is slowly worsening. He's becoming lethargic. So that is like a respiratory failure. So what you have to intubate. So this intubation is a type of physiologically difficult airway. So you have intubated the child, but you are doubtful about your ET tube position. What do you want to do and monitor? The other thing can be checked is your EtCO2. It's a very exciting new technology that measures CO2 in the exhaled breath continuously and non-invasively. It can measure where actually CO2 is getting produced during the cellular metabolism. From there, it is transported to the heart and exhaled via the lung. And so EtCO2, what all it will reflect your ventilation, it will reflect your metabolism, and it will reflect your circulation. There are different types of methods or monitors are there, like mainstream monitors, side stream, recently microstream monitors are coming. But what are the indications you should know? So especially to verify the ET tube, yes. And recently in the AHE also, they have included the effectiveness of the CPR. Like they said, if it's more than 20 mm EtCO2 during the resuscitation, that will improve your survival and effectiveness of ventilation. And there is some difference. The normal value is 38 to 40, and PaCO2 EtCO2 gradient is usually less than 6 mm. And what are the limitations, especially with the children with the ARDS, where you are giving higher rates, smaller tidal volumes, higher maps, and higher PEEP may lead to falsely decreased readings, and low cardiac output also will decrease the reading. So this is a monitor where it is showing the EtCO2 capnogram. So what happened to the child? So you have intubated the child and you are connected to the SIMV pressure control, pressure support with 12/8 PEEP and rate of 20, FaO2 60%. You have noticed something like this in the ventilator. So PV loop, pressure volume loop, you have noticed like this. What is it showing? It is like a beaking. So this was already discussed in the last ARDS class. So PV curve is mainly obtained in fully relaxed and ventilated patients. Okay, it will help in both static and dynamic respiratory system compliance can be determined. The lower inflection point, it represents appropriate setting of your PEEP, and upper inflection point, maximum setting of your PEEP. Okay, if it is something it's showing, means you're over ventilating, you may have to come down on your tidal volume. Or what is here, the PV curve shifted to the left means it's increased compliance. If it's shifted towards the right means it's like a decreased compliance. How good of your lungs you can make out by seeing this. But always remember, it should be done in a fully relaxed and ventilated patient. Patient should not take spontaneous breath in between. And the other common thing, very commonly ordered investigation, is your X-rays, which can have diagnostic, therapeutic, and prognostic value. So mainly what you will look, how is the exposure, how is the rotation, how is the infiltrates. Okay, expansion of the chest X-ray is also very important, especially after connecting to the ventilator or HFOV. How is the expansion of the lungs, which will give how is the recruitment and position of the central lines. If you have any line or ET tube, what is the position? Usually lower border of T2, 1 centimeter above the carina, position of the NG tube. If you have any other like pigtail catheter, all those things, it's very, very important thing is your X-ray. And also in diagnostic like pneumothorax and all these things you can see. So the X-ray is also very, very important. So what happened to our child? So saturation is 90% on adrenal infusion, PEEP of 10. What else you can monitor? Any other gadgets you have like non-invasive monitoring? Yes, the recent one is everyone, most of the centers they're having is your ultrasound. So what is this thing? I'm not going in detail pertaining to the ARDS. I'll just tell about show some things, important things. So normal lung ultrasound shows a clear linear pleural line, okay, with A lines. A lines are nothing but multiple horizontal reverberant artifacts, okay, and lung sliding with respiration. During inspiration, the pleural line will slide. Okay, so that's how if you put M mode here, that will show seashore sign. Why it is important, especially if you have a pneumothorax, the lung sliding won't be there. I will show you a video. So if you put a M mode there, it will be like something known as barcode sign on M mode. So you can see here, this is the left lung. You can see how it's the pleural line is sliding with both inspiration, expiration. You can see the right lung here. Only the left part of your screen is moving. The right part is there is no sliding. That indicates, and you have done an X-ray, what it shows? Right-sided pneumothorax. Okay, so you can make out by using this ultrasound. And other important thing is your B lines. Okay, what are B lines? Actually, the Lichtenstein criteria is there. These are like a comet tail appearance. You can see from the pleural line, no thick lines which are extending throughout the bottom. Okay, well defined, hyperechoic, which obliterate the appearance of the A lines. This indicates there is some interstitial edema. So this is very, very important, especially after you give the fluid bolus. You can see initially before giving fluid bolus, after giving fluid bolus, or over the days, how is there any developing of the B lines or anything? These are very important. There are some other things like consolidation and pleural effusion, which I'm not going in detail here. So what happened to our child is breathing on ventilator, saturation is 94%. Heart rate is 150, is on adrenaline infusion, saturation 60% to 80% you increased, ultrasound B lines are there, you increased your PEEP to 11, you have done a blood gas. So what are the uses of blood gas in PICU and how you will interpret? So this blood gas was actually in 1938, Blinks and Sco was studying photosynthesis by using the platinum cathode for oxygen monitoring. So at the time itself, they started this, and later the Clark's electrode led to the development of present whatever the commercial blood gas systems, which measure pH, PCO2, and calculate many variables. So the main thing, the blood gas helpful in managing and a patient's oxygenation status, okay, and also the acid-base balance. So what is an acid? Which has a tendency to dissociate and release the protons or H plus in the solution. And what is base? Which has a tendency to accept protons in the solution. And acidemia means your H plus concentration is greater. Alkalemia means your H plus concentration is lower. So that's the basic introduction. Remember, the arterial blood gas for the not only for the acid-base balance, for the oxygenation status of the child is also very, very important. And this is the famous Henderson-Hasselbalch's equation. You can calculate the pH of a buffer solution or the concentration of the acid by using this Henderson-Hasselbalch equation. So why should you order an ABG? So a normal pH is needed mainly for the normal functioning of the cells and tissues and for the optimal action of the various drugs. If the patient was on ventilator, mainly for the oxygenation status, if the child is having septic shock, seizures, cardiac arrest child, any unexpected deterioration in a critical ill patient, there are so empty number of indications why you will do an ABG. So what you want to do? You want to do an VBG or you want to do an ABG? If you are looking for the oxygenation status, you have to do arterial blood gas. Okay, but if you are looking for some metabolic derangement, then VBG is enough. So how VBG differs from your ABG? your pH is 0.03 less than your ABG, your PCO2 is 5 more than ABG, and your bicarb is 2 to 5 more than ABG, and lactate is more than ABG. So this is how the arterial blood gas is written: pH, PaCO2, PaO2, and bicarb, and lactate, and electrolytes can be written. So how to take a sample? As we already discussed, outline, if it is there, you can put the outline and take it from there. Otherwise, if you are puncturing radial, brachial, or femoral in the rare cases, and preemptive, you have to do a modified LN test, and it has to be analyzed within 50 minutes. If there is delay in analyzing more than 30 minutes, use glass syringes and ice slurry. And 0.05 ml per ml of Hep flush be there, and heparin coated electrolyte balanced syringes are better. And for samples with high leukocyte count and high platelet count, you may have a false value, so it has to be analyzed within 5 minutes. So this one, same thing I have written in the table: delayed analysis, your pH might be low, your PCO2 might be high, and PaO2 might be low. Excessive heparin, pH might be low, and PCO2 will be low. How air will change your ABG depends on your how is the patient's oxygenation status. Suppose if an air bubble is there, so that will bring your PaO2 to 150. Okay, if your oxygenation status is low, less than 150, it may be falsely high. Okay, if your oxygenation status is more than 150, it might be falsely low. So air bubble is like a tricky situation if you have, so avoid air bubbles in the arterial blood gas. And complications, you can have hemorrhage, hematoma, infection, arteriospasm, especially with sick children with multi-organ dysfunction, with coagulopathy, DIC. You have to be very cautious. The child can have bleeding from their arterial. And how it is, like I told, this is the traditional measurements. pH electrode will be there, PCO2 electrode, and PaO2 electrode. So these are the things, and the remaining things, everything will be derived one. So this is how the typical blood gas report will be there. These are the measured values at 37 degrees centigrade. And the temperature correction, is there any value to it? We will discuss. And the calculated values are there, which are the useful ones in that also we will discuss. And some entered data. So is temperature correction is needed? Actually, there is no scientific basis for applying temperature corrections to blood gas measurements. They say that uncorrected, whatever the uncorrected pH and PCO2 are reliable reflections of in vivo acid-base status. So temperature correction may not be needed. And it's just a spin-off of microprocessor capability. What about your calculated data? So something known as standard bicarb. What is standard bicarb? So how much amount of plasma bicarb after equilibration to PCO2 of 40? So it reflects your non-respiratory acid-base change, and it does not consider actual buffering capacity of the blood. So that is also, it's not useful. Standard bicarb. Base excess and base deficit. This concept is very important. What is base excess and base deficit? It is nothing but amount of acid or alkali that you have to add to a 1 liter of blood in the outside, that is in vitro, to a PCO2 of 40 at 37 degrees to maintain your pH of 4. So in simple words, if your pH is low, means it is acidic. So you have to add alkali to bring your pH to 4. So how much alkali is deficit, that much you are adding. So that is your base deficit or negative base deficit, base excess it is show. What is if your initial pH itself is high, that is pH of 7.5 and all, to bring pH to 7.4, you have to add acid. So that is the base excess, how much is. So normal value is -2 to +2. Less than -2 is metabolic acidosis, more than 2 is metabolic alkalosis. So this is how the blood gas report looks like. The pH normal value, what is the normal value? 7.40 plus or minus 0.05, that is 7.35 to 7.45. PCO2 35 to 45, PaO2 80 to 100, and bicarb 22 to 26. Okay, and the anion gap 8 to 12 and 10 to 16 with potassium. So the oxygenation parameters I already told, content of the oxygen and saturation. The important thing we will discuss. So this coming back to our child is on adrenaline infusion on SIMB mode. You have done a blood gas that shows like this: pH of 7.3 with PCO2 of 50 and PaO2 of 80. Your bicarb of 15 and base deficit of -10 and lactate of 5.5. So how do you monitor the oxygenation status? So you can see PaO2, it reflects your free oxygen molecules carried by your RBC and dissolved in plasma. Whereas SaO2, saturation, it depends on all the hemoglobin binding sites saturated with oxygen. content of oxygen, this already we discussed, depends on hemoglobin and saturation. So when you will say hypoxemia, if your PaO2 60 to 80, it's mild hypoxemia. If it's moderate, 40 to 60, and severe, it is less than 40. So by doing the gas, you will know whether it's either any hypoxemia, mild, moderate, or severe. And other thing which we can know is the PF ratio for a non-invasive ventilated child by calculating what is the PaO2 in the gas and how much FaO2 the child is in. So whether it is mild, moderate, severe, you can know. And same times, if it's a ventilated child, by using the mean airway pressure, you can calculate something known as oxygenation index, mild, moderate, or severe. So oxygenation trend is always important. You can see here one child started with 15, 13, it came down to 10, 9, again it came down to 6.5. So always oxygenation index trend is very, very important. The other important thing in the arterial blood gas which we can see is alveolar-arterial difference. So it is nothing but a difference, measure of the difference between how much is your alveolar concentration of oxygen and arterial concentration of oxygen. It is mainly important to differentiate the diagnosis of your hypoxemia. Okay, so and alveolar oxygen is depends on your how much inspired oxygen you have taken minus your PCO2 by respiratory quotient, and your inspired oxygen is depends on your how much is the atmospheric pressure. It's 760, and the water vapor pressure you have to minus, that is because of your humidification and all by the sinuses. At 47 you will minus from there, and how much percentage of FaO2 is he breathing. If it suppose is in room air, it is 21%. So 760 is your atmospheric pressure, 47 is your water vapor pressure, and how much FaO2. So that will give your inspired oxygen. You have to subtract from your PCO2 by RQ. What is RQ? RQ is nothing but it is calculated from the ratio of how much carbon dioxide produced by the body to the oxygen consumed. So how much oxygen consumed, if for one molecule of oxygen consumption, how much CO2 is produced. So that is your RQ. So that will gives your alveolar oxygen. Suppose here the PCO2 is 40 and your respiratory quotient is by default you take 0.8. So it is 100 millimeters of mercury. And your arterial side oxygen is this, it's a measure of this value you can see from the ABG itself. 90, the PaO2 is your arterial oxygen. So 100 minus 90, that is 10. So that is normal. So how you will know? Suppose if there is an oxygenation failure, you have calculated this and the difference is more, means the child is having some problem of like hypoventilation, that is oxygenation failure. Whereas ventilation failure, the you can see here PaO2 of this oxygenation failure mainly because of you have some problem in the in between, like shunt defect or VQ mismatch or diffusion problem. All these things will call your oxygenation failure because your gradient is very high. In case of ventilation failure, what is happening? You're taking inspired oxygen itself is low because child is taking very less breaths. The inspired oxygen itself is low, so the gradient will be normal. So the ventilation failure, it is normal, whereas in the oxygenation failure, it is more. Just remember alveolar, arterial. Alveolar is here, arterial is here. If any problem in between, it will be increased. Okay, like shunt defect, VQ mismatch and all. So now we come to the stepwise approach to the ABG interpretation. So before starting, I want to tell some ground rules. Okay, for any game or anything, we should have some ground rules, right? So what are the ground rules here in ABG interpretation? Always remember pH and bicarb, it will move in the same direction. Okay, pH and bicarb move in the same direction. Okay, that if it moves in the same direction, remember ME, metabolic cause. pH and PCO2 moves in the reverse direction or in the opposite direction. Reverse RE, it's a respiratory cause. Okay, pH and bicarb same direction, pH, PCO2 opposite direction. Bicarb and the CO2, if it's a simple disorder, the compensation and all, it should move in the same direction. Okay, in case if bicarb and PCO2 are moving in the opposite direction, means bicarb is high and PCO2 is low, means you should think about something known as mixed disorder. So there are some 6 steps. So what is the first step in interpreting ABG is your clinical assessment. Okay, clinical assessment based on your history, examination, and the initial investigations. So you will know the clinical setting. Suppose a child came with vomiting, what you will think the gas will be? It will be like metabolic alkalosis. Child with diarrhea, what can be the blood gas? It can be like metabolic acidosis. Okay, child with septicemia, okay, or septic shock. you will expect the gas to be a metabolic acidosis with high lactate. Okay, suppose child with DKA, so they can have again metabolic acidosis with ketoacidosis predominantly. So this is the clinical setting. So always remember what is the condition the child is having. Okay, so that is very important to determine. For if anyone asks you to do the gas, first to look into the gas and interpret, always ask why what is the indication you have done the ABG and what is the condition of the child, why the gas was done and what is the clinical setting. That is very, very important. So the next is look at the pH. Is the pH is low or pH is high? Okay, what is the normal pH? We told 7.35 to 7.45. If anything less than 7.35, it's acidic. If anything more than 7.35, it is alkaline. Okay, so the acid-base abnormality, whether look at the pH, is it acidic or alkalinic? So once you have done the steps, first is your clinical setting, you looked into the pH, you know whether it's acidic or alkalinic. So what is the next step? Next, look into the primary disorder. So you see here, the pH is low, your PCO2 is going in the opposite direction. So it is going in the reverse direction. Reverse is the respiratory is the cause. Here again, you see pH is high, your PCO2 is low. Again, it is the respiratory is the cause, respiratory alkalosis. And pH is low, your PCO2 is normal, your bicarb is low. That's why your pH is also low. Both are going in the same direction. That is metabolic acidosis. Your pH is high, your PaCO2 is normal, your bicarb is high, that's why your pH is high. Okay, so both are in the same direction, that is metabolic alkalosis. So first is your clinical settings, what is the condition of the child. Next is look into the pH. Next is what is the primary disorder. Okay, that how you will know by looking at the PaCO2 and bicarb. You will know whether it's a respiratory acidosis, respiratory alkalosis, metabolic acidosis, or metabolic alkalosis. So what you will do? Suppose the child is having respiratory acidosis, you have to determine whether it's an acute or chronic. How you will know? Yeah, the duration sometimes will say, but if it's like an acute respiratory acidosis, what will happen in the acute respiratory acidosis? The pH will be low, the PCO2 will be high. So for every 10 increase in your PCO2, your pH will decrease by 0.08. If it's a chronic, the PC for every 10 increase in the PCO2, your pH drop will be 0.03. Same thing in the respiratory alkalosis, but in the opposite side. Okay, always look into the pH also. How is the change? So respiratory, acute or chronic, you will know. Depending on the history, you will know, and depending on by using this formula, you can find out. There are some rules, Boston rules for compensation. Means why the child needs compensation. Suppose acute respiratory acidosis is there. So how much the bicarb should increase? So for every 10 increase in your CO2, your bicarb will increase by 1. Okay, if it's like a acute respiratory acidosis. If it's a chronic respiratory acidosis, for every 10 increase in your PaCO2, your bicarb will increase by 4 millimoles. Okay, if it's acute respiratory alkalosis, your bicarb will decrease by 2 for every 10 decrease in the PCO2. We already told one of the ground rule, your bicarb and CO2 both should move in the same direction. Okay, and chronic respiratory acidosis, the bicarb decreases by 5 millimole per liter for every 10 decrease in the PaCO2. So, and always remember this compensation. Overcompensation is also not good. Undercompensation is also not good. Okay, suppose the PCO2 of this child, acute respiratory acidosis, PCO2 of 60, you expect bicarb to be how much increase? 20 increase in the CO2 was there. So bicarb should increase by 2. So 26 bicarb plus or minus 2 you take. So if your bicarb you're seeing in the gas is 30, means overcompensating, that means it's some problem is there. It's a mixed disorder. Okay, then there is associated metabolic alkalosis also. Okay, so always remember overcompensation or undercompensation of this, in whatever the compensation is, some other disorder is also there along with your primary disorder. Okay, so what about the metabolic? So the fifth step, we have seen the clinical setting, we have looked into the pH, then you looked into the PCO2 and bicarb and find out what is the primary problem. Next, you have done respiratory compensation. So what about the metabolic? If metabolic process is there, the compensation is adequate or not, how you will know? There is something known as Winter's formula. So what happens in metabolic acidosis? Your pH will be low, your bicarb will be low. So how much your CO2 is expected that is depends on your 3/2 or 1.5 times the bicarb plus 8 plus or minus 2. Again, the same thing, if your measured PCO2 is more than your expected PCO2, always think of this is like overcompensation, concomitant respiratory acidosis. Okay. And for metabolic alkalosis, what is the thing? So metabolic alkalosis, how is the pH? pH will be high, your bicarb will be high. So every 10 increase in your bicarb, your PCO2 increases by 7. Okay, just remember, for every 10 it is 7. And metabolic acidosis, this formula is very, very important. So if metabolic acidosis is there, always look into the anion gap. Okay, anion gap is nothing but the measure between the anions and cations which are present in the blood. Sodium minus chloride plus bicarb. So all these values you can see in your blood gas itself. So the normal anion gap is 8 to 12. The unmeasured anions like albumin, phosphate, sulfate, ureates, and unmeasured cations, calcium, magnesium, abnormal proteins can change this anion gap. So why it is important? Suppose a child with septic shock with hypoalbuminemia. So the unmeasured anion, okay. So this albumin is low. It carries negative charge. So hypoalbuminemia, what it will cause? It will falsely show low anion gap. So how you can correct it? So anion gap adjusted for, just remember, for every 1 gram decrease in the albumin, your anion gap you have to increase by 2.5. That is the corrected anion gap. So anion gap observed plus 2.5 into 4.5 minus patient albumin. You can use that formula. Or remember, if albumin is suppose 3.5 is the normal, your albumin is only 2.5. So 1 gram decrease, your anion gap, it's falsely it is showing low value. You have to correct the anion gap by increase by 2.5. Okay, so this is important. And once you know anion gap, you will know whether it's a high anion gap metabolic acidosis or normal anion gap metabolic acidosis. High anion gap mainly because of some accumulation of some acid in the body, mainly, or some accumulation of some substances like lactic acid, ethanol, salicylic acid. There is some mnemonic like mud piles, which everyone is familiar with. So just remember the causes of this high anion gap metabolic acidosis. What about the normal anion gap acidosis? The normal anion gap acidosis mainly occurs because the child is losing the bicarb either in the gut or in the kidney. Okay, the mnemonic is hard up. Like main causes, especially in the ICU setup, which we'll see is child is having any renal tubular acidosis or diarrhea. These are the two important causes where we will encounter this normal anion gap acidosis. So if it's a normal anion gap metabolic acidosis, how you can differentiate both the things? We can calculate urine anion gap. Okay, remember urine you can't measure the bicarb because it's volatile. It will be quickly converted to CO2. So you can't measure that. So urine anion gap always sodium plus potassium minus chloride. So the non-renal causes, what will happen? If the acidosis is due to the loss of base like bicarb due to the bowel issue, like child is having diarrhea, then what will do? Kidneys will try to compensate by increasing your ammonium excretion, and it will cause bicarb H plus loss from the body. So what will happen? The urine anion gap would tend to be decreased. So that is the increased ammonia, that tetrahydroammonium. What will it will cause? Urine anion gap becomes negative. So always remember gut causes. The gut is losing bicarb. So kidney will try to compensate and it will try to become negative gut. So remember that urine anion gap will be negative in gut causes, whereas in the renal bicarb loss, the renal itself is issue. So it can't compensate or it can't excrete the H plus ions from the body. So urine anion gap will be positive here. So remember, urine anion gap negative, it's a gut cause. Urine anion gap positive is renal cause. Because of the gut, the renal is able to compensate, it is negative. The renal itself is affected, so it is positive. So we have looked into the clinical setting. What is the pH? What is the primary disorder, metabolic or respiratory? If respiratory, how to calculate the compensation? If metabolic, how to do the compensation? If high anion metabolic acidosis causes, normal anion gap metabolic acidosis causes, and urine anion gap to differentiate between the gut cause or renal cause. Then the last step, very important step is there any more than one disorder or mixed gas? How you will know? There is something known as delta gap ratio. So when to consider mixed disturbances, your pH is normal, but your PCO2 or bicarb is abnormal. Always think it's a mixed disturbance. Okay, and PCO2 and bicarb, what is our ground rule? PCO2 and bicarb should move in the same direction. If they are moving in the opposite direction, then it's a mixed disturbance. And one more thing which we discussed, the degree of compensation for primary disorder. If it's overcompensating, undercompensating, then also think it is a mixed disturbance. And always remember, important thing, whatever the compensation will do, it will never normalize the pH. So pH is normal, sir. PCO2 is high, bicarb is high. No, that is abnormal. That is a mixed disorder. So these are the mixed disturbances which we can see. And how to find out that delta gap ratio, that is mainly by the change in the difference in the anion gap -12 by delta bicarb, 24 minus bicarb. So how you will interpret this? So don't worry about all these things. We will discuss with the case in the next 4 scenarios.
Siva, I think we'll go to the case and you can come back and show them.
Yes, so this is the last slide.
Sure.
So the delta gap ratio, if it's usually it should be between 1 to 2. That means it's uncomplicated high anion gap acidosis. So just remember, basically the acidic anions, whatever, it should titrate the bicarb also. Okay, so and both are appear to be in the same, and it should be 1 to 2. If anything is abnormal, like if it's less than 0.4, means there is some problem in titrating the bicarb. So the body is not able to cope with that. So they can have normal anion gap acidosis. If they have bicarb is overcompensating, then they can have metabolic alkalosis. So it will be more than 2 in those scenarios. So just remember 1 to 2, it's like a pure high anion gap acidosis. 0.4 to 0.8 high anion gap with normal anion gap, less than 0.4 it's not high normal anion gap acidosis, and more than 2 it's metabolic alkalosis. So the stepwise approach, the clinical setting is very important. Look at the pH, because these steps are very important, because the case discussions, please will follow the same steps. What is changing the pH? Look at the PCO2 and bicarb, if respiratory, acute or chronic, if compensation is adequate or not. And the next is your metabolic, whether compensation is adequate or not, whether high anion gap, normal anion gap. Step 6, if any more than one disorder present, or delta gap ratio you can calculate. So we will do some case scenarios here. I want it to be a little interactive. They can unmute and they can answer. If anyone volunteer, it will be nice. It's a 2-year-old child intubated for COVID pneumonia on lung protective strategy ventilator measures. ABG done 1 hour after ventilatory settings was showing like this. Anyone want to take up this? Anyone from the audience? Like in a stepwise, we can go. Anyone?
A clinical setting is COVID pneumonia.
Yeah, very good.
pH, second step pH is 7.2, so acidosis.
Okay, very good.
And,
what about the
PCO2 and pH are in the opposite direction, so respiratory pathology.
very good. So what about the compensation for the respiration? How much should be your expected bicarb? So this is for the 1/10. It's like acute respiratory acidosis. If you take the bicarb should be expected should be 24 to 28. So what is your bicarb here? 26. So this is the child with acute respiratory acidosis. So anyone want to take up this? Anyone else? We'll follow the same steps. What's the clinical scenario here? You can see child with fever, rash, breathing difficulty.
So COVID pneumonia with shock, hypotensive shock.
Yes, very good. So the child is having fever, hypotensive, poor perfusion. So it's like a probable septic shock. What about the pH here? 7.15. Normally 7.35.
Acidosis.
Acidemia, very correct. So what about what is changing the pH here? So pH is 7.15, PCO2 is 15. Will PCO2 15 will cause this pH?
No, it should be the bicarb.
Bicarb should be the thing. So both are in the same direction. So it's the metabolic. So then what you want to do? Metabolic compensation. So how much it will be?
It should be somewhere around 14 to 16. So its compensation is fine.
4 to 8.
Okay, very good. So so its compensation is okay. And what about the anion gap here? Without including potassium, you can see.
It's 25.
Yeah, it's around 26, right?
20,
so what is your comment on the anion gap?
The high anion gap.
Okay, but you want to know whether is there any other disorder? Delta gap you want to calculate and see. The change in the anion gap by change in the bicarb here.
Maybe.
Yeah, how much it will be here? Your anion gap is 26, the normal is 12, and your bicarb here is 4, normal 24. So how much it will come? Your numerator will be 14 by 20.
It's around
Oh.
0.7.
Yeah, 0.7. So that indicates what? Even though your anion gap is showing hugma, here it is gas, your mixed, it's like a high anion gap acidosis. That might be probably due to septic shock, and normal anion and high lactate, and normal anion gap acidosis is also there. That might be due to your high chloride here in this scenario. So that's why the importance of you doing your delta gap comes. Okay, so we will move on to the next one. So you can take up this same steps. One of you with low grade fever, loose stools for 1 day. It's a simple one. Yeah, she was severely dehydrated. ABG showed 7.1 pH, PCO2 14, PaO2 260, bicarb 5. Anyone want to take up this? What is the clinical scenario here? Child with fever and loose stools, right? Child with like acute diarrhea. What is the pH here?
Is acidosis.
Is it acidosis? Very good. And what is causing the pH? Is it again the bicarb? PCO2 can cause this pH? No,
It's bicarb.
it's the bicarb. So it is your metabolic thing. So how much will be your compensated metabolic acidosis? How much will be your expected PCO2 here?
5.5 to
Yeah,
9.
that's 14 to 16 somewhere. This looks like
Yeah.
compensated.
Yes. So, and your anion gap?
Anion gap is around 10.
Yes. So it's like a normal anion gap metabolic acidosis. It's because of the loss of bicarb in the gut, and also child is having high chloride. Okay. So that might be the reason. So anyone want to take up this last one? 4-year-old child intubated for COVID pneumonia on high ventilatory setting and on diuretics with PEEP of 10, mean airway pressure of 16. You have done a morning blood gas, which is showed like this. What is the clinical scenario here? What is this child is having? He's on high PEEP. Child with an ARDS, right? On diuretics. So what is the pH here? What is your comment on the pH?
pH is normal.
pH is normal. Yeah, very good. So what about any other abnormalities there in the gas? We have.
Yeah, both the CO2 and the bicarb are elevated.
So both might be the culprit for making the pH normal. I told no some rules, like if the pH is normal but your PCO2 and bicarb is abnormal, that is like a mixed disorder. Okay, so here both bicarb and CO2 are abnormal. Okay, so how you can see what is causing what? So if you want to see for respiratory acidosis, if you're thinking the primary thing, how much will be your expected bicarb here? If you're thinking like a respiratory acidosis acute thing, so how much the CO2 increased here from 40 to 66?
If it's acute, should be increased by 2 to 3. Because for every 10, there should be rise of 1.
Yeah, so here it should be somewhere between
26 to 28, maybe.
26 to 28. If it's a chronic, it should be between
5, no,
yeah
4. Yeah,
4.
should
For
be
every,
around 8.
yeah,
4
8.
per 10. Yeah,
Yeah, so
somewhere
that's
around 8 to 10.
so that's so respiratory acidosis. If you're taking this child is intubated for long time, like a chronic respiratory acidosis, your expected bicarb should be 30 to 34.
34.
Take, but what is the bicarb here? It is 44. So there is definitely respiratory acidosis and metabolic alkalosis component. You can do in the either way also. The metabolic alkalosis expected PCO2 you can calculate, it will come more than that. So it's a mixed disorder. Okay, respiratory acidosis probably due to the ARDS and all, and metabolic alkalosis because you are giving diuretics and all, child might be have developed metabolic alkalosis. What about the OI of this child? Oxygenation index. You have the mean airway pressure, you have the FeO2, you have the PaO2. Anyone want to calculate the OI? How much it will be?
4.
4. How did you get 4?
You can show the formula, you can tell them.
Yeah,
So
it's
the
MAP.
oxygenation index is depends on how much you are giving and what you are getting. So what you are giving is mainly depends on your mean airway pressure and your FiO2. That multiplication divided by what you are seeing, that is your arterial oxygen saturation. Okay, that is your 80. So 16 into 60 divided by 80. So that will be around 12.
Okay.
Okay. So this is the thing, and so each parameter is very, very important. Whatever we are monitoring, we should know our targets, and every parameter should be checked after every intervention. And always remember, the physiological variations have a wider range in children. It is not only a mission, it's all about the people and labs. Everything is important. And always remember, the numbers don't tell the whole story. It's only the patient does, and it's up to us how to interpret. Thank you very much.
So probably I think on the discussion, we can first focus on the blood gas. If anybody has a discussion or questions, and then we'll go to the monitoring. There are a couple of questions in the chat box even. So over to Muniya and Abhishek among the blood gas. Anybody has any question? It's straightforward. Siva has presented in detail in a stepwise fashion. But if there is any queries on the blood gas area, we can have that now, and then we'll go to the monitor. So in the blood gas, as he was talking about, see, we are not playing with numbers alone. We are playing with human lives. So the patient and the clinical condition is very, very important. In that clinical context only, we need to look at the blood gas and interpret. And not only the acid base, oxygenation as well as oxygenation status is also important. That's what the pH ratio and why they were discussing. And there is a question on something about monitoring. We can go. I think that's not a question about saturation and the PaO2, and now there is a question on EtCO2 with a PCO2. Siva, would you like to take on that one by one?
Yes, sir. The first one is that which one, sir, to take up that
See,
PaO2,
that was
SpO2?
question. I can read that for you. That is, so in a missing child, then Gaurav was noticed that saturation was around 95 to 98% on ventilation with FiO2 of 5. But on ABG, PaO2 was only 55. We just want to know what's the why, what the interpretation clinically or the gap.
So the PaO2 values usually will be lower than your oxygen saturation values. Okay, usually it's just a reflection of where is your oxygen saturation curve. So suppose your oxygen, your saturation might be 95, but your PaO2 in that curve might be falling at 55. So that should raise our concern. That's why I told the SpO2 may not give a clue. We have to think about what are the things which is causing right shift or the left shift. So I think that should, in this child, I don't know. PaO2
it's an arterial gas. Gaurav, you can mute and answer. Discuss that. It's not a spurious value.
No, sir, it's an arterial gas.
Okay, what was the platelet count when there is a high leukocyte or a thrombocyte?
No, sir, it was within the maybe slightly increased, sir, but definitely not.
That also can, when the electrodes, when there is a thrombocytosis, that can give a spurious value of this PO2. Sorry, not SpO2, PaO2 values can be. And but otherwise, how was the child finally? Was doing well, or how is it doing at the moment?
Child was discharged, sir, at the end of 10 days.
So, but did you notice is one of a value or the serial values there was a decrease?
For the serial value, sir, over a period of 2 to 3 days, I observed the same gap between PaO2 and SpO2, and I didn't know how to react.
Okay, so that was an arterial line, and you could get the gas.
Yes, sir.
Okay. And did you able to correlate with your maybe the lung and all, everything was fine, or?
Lung was fine, sir. Lung was fine.
So yeah, so that is as when we are putting down this P50 also has a role in that deciding mainly when we're plotting in the oxygen dissociation curve. So see, when Gaurav, I just want to ask you, this child clinically, when he was in shock, you could find that, or the child was not in shock as well?
Child was in shock, sir.
Yeah.
Child was for a long time.
Yeah, but also could explain in your oxygen consumption and delivery as well.
So
and one more question you have put on the BBG and ABG correlation in the DKA.
So DKA mainly we will be looking for the if you are looking for mainly the metabolic parameters rather than the oxygenation thing, the VBG should be enough. Unless you are looking for the oxygenation status, that's what everywhere the guideline says. If you're really looking for the oxygenation thing, or child is having some other fluid overload, or you look into the oxygenation status, yes, then definitely arterial blood gas. But if you're looking mainly in the DKA for the metabolic thing, then VBG should.
Okay, that's about the ETCO2 and the PaCO2. Want to tell about the gap?
Yeah, the ETCO2 and PCO2, usually there will be less gap will be there, but depending on the conditions, again, if the child's cardiac output, again, if it's low, the gap will be increased. Okay, there are various conditions which will increase the gap. If their child had decreased circulation, or suppose you're ventilating with a high PEEP, then the ETCO2 may not give a true picture of your PCO2. So you want to add up on that? Anything?
Yeah, usually it will be 2 to 5 is okay. If it is increased, there can be a respiratory dead space or a low pulmonary circulation or a VQ mismatch also can contribute to that. So, and another thing is about your what stream you are using, mainstream or a side stream PCO2. That is also quite important to know. And Joshi has commented about there is a doubt nitroprusside overdose. How to diagnose based on ABG?
So nitroprusside mainly if you are worried about like for methemoglobinemia and all, you can look for the co-oximetry. That may give the thing.
Yeah, methemoglobin, but nitroprusside, what is the causes?
Mainly it's a cyanide thing.
Cyanide. So it's like a more of a carboxy.
More of the carboxy hemoglobin.
So,
yes.
So you need to have
will give us
co-oximetry should be there in the blood gas, where we can measure the co-oximetry hemoglobin, the abnormal hemoglobin. Then it is useful to diagnose or to interpret. So any other questions? And there is question we can ask. And see, I just want to comment mainly in a nutshell. Abhishek is there. You want to say anything? Muniya has joined back? No. So mainly in the monitoring. Oh, you're back. Yes, Muniya.
Am I audible now, sir?
Yes, please.
Okay. So nothing. I just want to say that it was a very extensive presentation, and we cannot overlook the importance of monitoring a sick child. There's so many studies overall have shown that your mortality depends on how severe the child is landed in your field. So worldwide there is this practice or system of having a rapid response team, which constitutes an intensivist doctor, intensivist nurse, and a respiratory therapist. So their main role is to pick up children who are deteriorating fast enough so that they don't worsen so when they land up in ICU. So this is very important. In the first initial topic of he talked about.
So in the monitoring, so you were talking about Siva. I just have some questions and you can discuss that. So we started with the hemodynamic monitoring RSP. Most of the secondary hospitals, they may not have all these gadgets when we talked about, like even invasive arterial blood gas might be difficult. So I'm quite interested in the study which you showed, Antomedia Sharp, that's about capillary refill time as well as lactate comparison. And they said capillary refill time is a great variable, right?
Yes, sir.
Can you explain that a little bit more so that it can be useful for others?
So in that study, mainly for the adult septic shock they have done. So they were randomized into capillary refill time group and lactate they have measured in the other group. And they looked into the primary outcome at 28 days. And they didn't find any difference in the mortality at the end of 28 days. So that's why especially in the machine hospital and all, you need not measure the lactate. You can measure the simple by using this capillary refill time. And how you will measure the capillary refill time, as I mentioned, you have to keep the level above the level of the heart. You have to press it till it blanch and then release it and see how is it. And you have to check for how many seconds. Okay, and they have showed also if its CRT is less than 2 seconds, your cardiac index and all are very good. That's what they have showed in so many studies. So that is a very important parameter which we can use.
And so you said capillary refill time is very important. I do agree. We do check on the pumps and soles. You keep it above the level of the heart and get everything. But it has its own pitfalls also. When the ambient temperature is low, your capillary refill time can be prolonged and can be spurious as well.
Yes, sir. Yeah. With the hypothermia and hypoperfusion and all, sometimes, we can face that CRT might be prolonged and all. Yeah, that's
so
there.
in that context, I would say we have to keep, it's not as a single variable. You need to, in combination with your other heart rate, pulse volume, capillary refill time, and other sensorium, urine output, all this together, it's a very important part. So clinical examination has its own value. At the same time, we need to take it in the context along with other variables. Deepika would like to say, add on something.
So I just want to know, when they're saying this lactate measurements, was it by capillary tubes, venous or arterial? Because there will be a +-2 difference sometimes. So how do we know that?
I don't know, ma'am, how they measured there. I have to look into that.
No problem. I just want, because even do like a capillary or something.
So regarding the lactate query, whether it's an arterial or a venous, I think in the 90s we're looking at the trend of the lactate. So you're looking for a lactate clearance trend. So if you're looking at a trend, that's follow. If you're doing a venous gas, follow the venous trend. If you're doing an arterial gas, follow the arterial trend. So that is what the level is jumping between the two.
It's always rather than a single value. Lactate clearance also has its very good correlation in your mortality that is found. But in my point here is sometimes some places they may not be able to do even a blood gas. In that situation, we are forced to go by only clinical parameters. So clinical parameters are always important, but it has its own pitfalls in a patient who is in shock. That's what in a non-invasive and invasive multimodal monitoring versus non-invasive done by Dr. Suchitra Ranjitan has published, and it has come. That's what the new PALS guidelines also is based on. So it might vary. It might not give the cold, warm, shock differentiation is a little bit of vague terminology nowadays in context of a clinical examination. Yes, definitely, I agree. Invasive, if you have an arterial line, that will give more valuable information. But if you don't have, you can go by the same out rate as he's put on the therapeutic endpoints, coming down on the tachycardia, pulse volume, and capillary refill time also will be useful in managing the child. Abhishek, you want to say something?
Yes, sir, that's true only what you have said, because most of the peripheral setup, we won't be having all these gadgets to see how the child is going on. So for us, what we feel that like fluid responsive also, we have to see the heart rate, respiratory rate, and the liver size. So we may not have other things like PPV and all to see the fluid responsiveness in the peripheral setup. So that's why the clinical things are very important here.
Yes. So nowadays, we'll talk about that detail in the shock lecture. So you talked about fluid responsiveness. So in simple clinical terminologies, we look at the positive effect that you give, whether it is a 5 ml per kg or a 10 ml per kg. You look at whether the heart rate is coming down, your pulse volume better, capillary refill time is getting better, urine output, sensorium, all that things you will look. But at the same time, you look at respiratory rate and rals and crepitations, liver size, gallop. But what about the role of passive leg rise, you said, but in pediatric or an infant and a pediatric population, it's quite not that popular, right?
Studies.
Shiva?
Yes, sir, there are not much of literature looking into the passive leg raise test, especially in the pediatric ICU. There are one or two, I think. Otherwise, it's well proven in the adult thing, and especially in
Yeah, but
children.
still we can go within the older children. But as he said, there are some contraindication if you have an abdominal pathology or if you think of an increased intracranial pressure, you might not do that. Otherwise, yes, it has its role. And you do always just touch the liver and see like a hepatojugular
reflex.
So what do you say about it? Some person want to look at that and see, oh, it's the BP is going up. Can I give volume?
Yes, sir. That's all like a transient thing. You're by pressing the hepatic thing, you're just pushing the fluid and you're trying to increase your preload there. So it might be transiently, it may increase and it may later come down. If it's persistently, if it's in the high, then we may think it's like a fluid overload state. Again, it's like.
But it is not but supported with the evidence-based literature.
No. Nowhere it is.
So that is also we can't. So the fluid responsiveness, when you say, you talked about ultrasound quite a bit, and what is the one or two points if you have to tell as a take-home message for them? What would you say? Ultrasound as a monitoring tool.
Yes. So ultrasound, if you have, just look into the IVC. Okay, and look into the IVC and see if it's a spontaneously breathing patient during the inspiration and expiration. Is there any change? Okay, is there collapsibility? Because the more the variability in the IVC, that indicates the child is more volume depleted and needs more volume, is in the steeper portion of the Frank-Starling curve. Same time, in the mechanically ventilated children, the distensibility variability you can see. Okay, that thing you can see, and also at just by having, if you can do a echocardiography, just do a subcostal view, okay, and just look into the how is the heart contractility, okay, how is the heart contracted. If you can do plaques view or the apical view, that is good. But if you can do these small things, mainly to see whether is both the ventricles touching each other, something known as kissing ventricles, they will say. If you're seeing something like that, that child requires fluids. Okay, so these are some of the things which we can do if you have a ultrasound. And after giving the fluid bolus, you can see the B lines, as which I showed, the vertical lines, thick hyperechoic lines. If it's developed, means child is going into the fluid overload state. So ultrasound is a very, very useful tool, like non-invasive, very useful tool. If you have, I think I suggest you to use it whenever you're giving a fluid.
Absolutely. So as we are saying about lot of gadgets coming up and new like all this pulse pressure, stroke volume, so many things are there. And not only that, invasive as well as non-invasive cardiac outbound monitoring. But still in pediatric population, they are very, very difficult to get them. And it's not much validated as well. So we are coming back after decades of sepsis or shock management or hemodynamic monitoring, basically to our clinical acumen. But you need to remember this clinical thing in an acute resuscitative phase may give a false information also. So that's what about the cold and warm shock in the sense. So remember that you need to stand at the bedside. It is not one value, as Muniya was saying about it, it's not one value, it's the trend. It is the trend is important. So that's what Siva showed, that flow chart of an ICU. The nursing monitoring of a heart rate coming down or going up, or the blood pressure is your systolic or diastolic, more that is the mean, which gives more important value, pulse volume, as well as capillary refill time, urine output, all as a serial values gives important. If you have a blood gas and an ultrasound, it add values like lactate clearance and SCO2 monitoring. In respiratory, you talked about many things. I would like to say about the value of SF ratio. PF ratio is what you need to have in blood gas arterial line, you may not have it, but if you are able to monitor the FiO2, if you are able to say approximately you're giving an or air or oxygen mixture, or if you're having a high flow or airflow machine, you can have an FiO2, or through an NIV, you can measure the FiO2. Even if you don't have, you can have an oxygen analyzer, probably that also gives an FiO2. So saturation by FiO2 is also an important tool to monitor a child in a respiratory monitoring, whether the child is an ARDS level or is the child is improving or deteriorating. By looking at that is very, very important. ASF ratio has been incorporated into the pediatric ARDS by the policy definition. So it is very important tool to screen and monitor a patient when we are monitoring a respiratory distressed child. Muniya or Abhishek, you would like to comment anything on the respiratory monitoring?
Yes, sir. So again, going back to the basics, it's very important that before we go into the advanced monitoring, stick to the basics. Two most important things in the respiratory settings, I would say, is the rate and the effort of your respiration. That's very important to recognize. Okay? So a child who's, if you've been constantly monitoring the child and looking at the trend, a child coming with a respiratory distress might have increased work of breathing. But as a child progresses towards respiratory failure, the work of breathing might not be there. So it might be in a false hope that, okay, the respiratory distress is improving. So you cannot just look at one clinical findings. You need to correlate what is the rate, what is the effort, what is the saturation, what is the sensor. When we talk about respiratory, don't just look at the chest, look at the as a whole.
Along with that, in respiratory monitoring, suppose the pulse oximeter, we are seeing the saturation. So along with the clinical things, if we have the facility for blood gas, we have to see the blood gas. Suppose we are seeing a good numbers, more than 97% of saturation, but if the gas is showing alkalosis, itself it will show that oxygen hemoglobin dissociation curve will be in the left side. Means tissue may not have that much of oxygen dissociation, and tissue might be in the hypoxia. So all these things we have to take care while we monitoring the respiratory.
So respiratory distress and failure has to be clearly differentiated. Respiratory failure where your sensorium goes down, despite adequate oxygenation, you might look cyanosed or a low saturation, as we know, less than 90 or equal to 94% hypoxia, where you may not try non-invasive ventilation, that we talked about, that need an advanced airway. So all this can be in a close monitoring of respiratory and hemodynamics. It's very, very helpful. Some centers, they use respiratory scores, like clinical respiratory score, based on the same parameters, but your auscultatory findings, your use of accessory muscles, respiratory rate, like that. Siva, there is one question in the chat about hyperchloremia and acidosis after saline boluses.
Yeah, they can have a hyperchloremic acidosis, like a normal anion gap. That might be due to your overwhelming your renal function. Mainly renal, they have a function of having the chloride handling. So if you are overwhelming, they can have hypochloremia. Again, that saline boluses you have mentioned. So already by giving the saline boluses, again, it's like in simple terms, you are diluting your bicarb, and that will also worsen the acidosis. So the definitely hyperchloremia contributes significantly to your metabolic acidosis. It's mainly normal anion gap metabolic acidosis.
So, but yes, there is some contribution, but still there is a controversial discussion whether is it really a harmful way of this hyperchloremia and acidosis. Some papers earlier come with acute kidney injury related to this hyperchloremia. Now, yes, still a debatable thing. Yes.
Only one thing I want to add is we need to remember the importance, because in a resource limited area like in a mission hospital, a doctor cannot be present 24/7 to monitor the early warning signs. So it's very important that for your center, you have an individualized warning scores, like how CDC has PACT score, like that, and train us, because in the end, they're the ones who are monitoring the patients and they're going to be at the bedside. So train them in such a way that, okay, if this number rises, this condition happens, to alert doctors. So that is very important, because again and again, I'm emphasizing it's very important that we recognize early deterioration for a better outcome.
Absolutely. So Muniya is talking about early recognition of clinical deterioration to have a better outcome, whether it is in the emergency or even the ward, even more in ICUs. Even if you don't have a great just simple measures and clinical parameters can help to identify the early deterioration. Then only the outcome will be good. I'll just come to the last slides. So thank you, Muniya and Abhishek. It was wonderful to have you guys, and it's really a pleasure to see. And Muniya and Dr. Abhishek, thank you for moderating the session. Siva for giving a full excellent overview of both. It's like a two talks, but it's quite important. You touched both clinical as well as using gadgetry monitoring as well and ABGs. So thank you for the good interaction and discussion of about the blood gas and monitoring. And thank you so much, everyone, and especially Muniya and Abhishek.
Thank you so much for inviting us. I think you have already taken initiative in teaching not just the ICU people, but even the pediatricians as well. So, and I really appreciate that. And this is one of the long series of lectures we have had in a really long time, I think. So I congratulate the entire PICU team for the effort. Thank you, sir.
Thank you, Muniya. Abhishek.
Thank you, sir, for inviting us in this session. And it's after a long time that we all work together again in the management of sick cases. We have highlighted some very good points. So thank you so much. But what I feel that there's a very good initiative from CMC side that for that discussion and teaching for the people who are working in the peripheries to manage the sick child. So it's a very good initiative from CMC PICU team. I just wishes them good luck.
Thank you, Abhishek. Thanks, Siva.
Thank you.
Thank you very much.